So the aim of my presentation is to look at neurological deficit of the foot and ankle and some of the implications for practice. So I aim to look at two examples of neurological deficit in MSK podiatry practice. These are part of my particular interest areas in terms of my research. And today I thought it would be useful to just highlight some of the implications of neurological deficit that we might see in podiatry practice and give you a couple of evidence-based take-home messages at the end of this short presentation. So the two examples that I will use that we see commonly in podiatry practice are vascular trauma and stroke, and that has an implication on the leg and foot that we see commonly within podiatry. And these are the UK figures. The other common area that results in us seeing neurological deficit in podiatry practice is in people who develop diabetes. So I'll use these as the basis of the rest of this presentation. As podiatrists, we may in clinical practice use observational assessment as part of our clinical practice. And we may do a visual assessment. We may use instrumentation in order to try and semi-quantitatively assess neurological innovation. And when we have a look at some of the literature, Fernandez just last year undertook a systematic review of observational gait analysis to look at its reliability in practice. And the conclusion of that review was that really we should be looking at instrumented analysis in order to try and get the most reliable results for measuring the effects of neurological deficit on gait. The reliability of some of the common clinical examination techniques that we use, such as the use of the monofilament and the use of the testing for reflexes, has been assessed by Lanting, and these also have implications for podiatry practice in terms of the reliability. The monofilament appears to be the most superior of the tools that we use in terms of the reliability for interpretation of findings. So in terms of assessing neurological deficit as podiatrists, there are a number of methods that we can use which are the most reliable and accurate. So we may wish to use kinematic data, kinetic force plate data, or we may wish to look at plantar pressure analysis. And this can vary dependent upon which patient group we are assessing. For people who have had a stroke, some of the common problems that we see in this particular group are things such as foot drop, where there is inability to get ground clearance of the toes during the swing phase of gait, and also commonly seen is foot equinus. However, these assumptions are not always correlated to the findings within the literature. So, for example, some work that was done here at Salford University several years ago aimed to challenge some of the assumptions that foot abnormalities are commonly asymmetrical, that they follow an equinovarus pattern, and that they cause limitations in walking. The findings of this study was that foot posture abnormalities were only found in about 30% of stroke patients. So we may not, as podiatrists, find that our stroke patients are always presenting with foot posture problems, and their deformities or problems may well be limited to the upper limb. Interestingly, in terms of the presentation of the posture of the foot, this study found that equal numbers of people had excessive supination or pronation. So we wouldn't always expect to see the foot to be a drop foot or in the equinovarus deformity position. Some of the implications for practice from the literature suggest that we should be exploring strength training for people who are rehabilitating from stroke, and that we should think about using foot orthoses in order to try and help improve gait and mobility, or perhaps ankle foot orthoses with the help of our colleagues in prosthetics and orthotic discipline. And suggest Kathy Bowen and her team at Southampton undertook some research around the footwear habits in people who had neurological deficit and suggested that it was really important to establish safe, effective footwear in order to facilitate the rehab and also reduce the risk of falls prevention, something that Antoine's just mentioned in his previous presentation. The second example that I'd like to speak about today is the deficits in neurological status that might occur in people who have diabetes. And there are a number of aspects of deficit that might present in people with diabetes. Some of the common ones, and particularly to the area of research and interest for me, is around limited joint mobility, deformity, and the lack of sensation that might occur in this particular group. Some of the assumptions regarding neurological deficit for people with diabetes are that offloading is an important feature and that has a benefit to reduce the risk of foot pressure, but that it might be difficult to try and strengthen and improve foot mobility in people who have diabetic peripheral neuropathy. Increasing mobility is a concern with people who have neurological deficit in diabetes because it is a concern that that might potentially affect foot pressure. However, the benefits are that it improves mobility and helps to increase strength and potential muscle mass. So when we look at some of the literature that has challenged or confirmed some of these assumptions, Synacor did find that impaired ankle and foot mobility will cause greater stresses, and the impact of those forces may well contribute to foot ulceration. So the links between neuropathy and foot ulceration has quite a strong evidence base in people with diabetes. This was further substantiated by the work that was undertaken by Fernando around the risk of biomechanical changes associated with neurological deficit, further increasing the risk of foot damage. Some work done by Joanne Payton et al. At Plymouth University looked at the types of standard offloading insoles for people with diabetic peripheral neuropathy in order to reduce pressures. And their group found that whilst offloading is considered to be gold standard to reduce the risk of peak pressures, the design of the foot orthotic needs to be considered very carefully when a person with diabetes has neuropathy, as it may well increase the risk of postural instability. So to consider the inclusion of textured design, textured covers, and think very carefully about the design geometry of foot orthotics in order to try and reduce that risk of instability. In particular, the profile of the support in the arch. Anita Respovich and the team in Australia looked at the area of limited joint mobility as a potential risk factor for plantar foot ulceration, and limited joint mobility is thought to be associated with neurological deficit. And within the area of limited joint mobility, there is a trend of measuring static ankle joint dorsiflexion as a surrogate measure as for limited joint mobility. The study here about 10 years ago found that actually there was very little correlation between dynamic and static ankle joint dorsiflexion and peak pressure. Therefore, it may be that further research needs to look at measurement of joint mobility using other joints other than the ankle, which clearly brings its own challenges. So in conclusion, the evidence-based messages from the literature for people with neurological deficit presenting in podiatry practice for the two examples that I've used are that we should think about what the safe and appropriate footwear is to improve function and gait speed, but also to help to reduce falls risk. And when we are providing foot orthotics to reduce pressure, that we need to consider very carefully the texture of that foot orthotic and the geometry of it. So when we try to improve function and reduce plantar pressure, we don't compromise balance, and that we should always look to try and, where possible, improve the strength and the stretching and function for our patients. Thank you very much.